Thank you very much for the invitation. I'll have to admit that this is very disorienting to be at a Rotary event and not talk about polio. I think Carol has highlighted some of the contributions historically of Rotary, but I would like to also add one, because I was actually at CDC when Polio Plus started, and the partnership that evolved from that once the appropriations were increased. A little known fact is that a local club began a work with the CDC that was related to the surveillance contributions that the laboratories were going to need to do in Africa and places where there was no infrastructure. And so part of the reason for the activities was to get these labs functioning, build the infrastructure. And at the initiative, first of a local club, but then later District 6900, they collaborated with us to address the needs of these laboratories, particularly in Africa. And this became the seed for the Polio Plus Partners program. And so it actually initiated out of local club and District 6900 to make this major contribution to the program. John also mentioned we have this CDC disease where we can't talk without slides. So my apologies, because there will be slides. But also, I also want to respect the fact that I'm standing between you and lunch, and that always makes me nervous. But we'll try to keep roughly to time and not starve you for the rest of the afternoon. So what I'd like to cover today is acute flaccid myelitis and give you some idea about what we know, but to also address some of the concerns that were raised, particularly starting in 2014 when this was labeled a polio-like disease. And I'll explain why, of course, it is a polio-like disease, but why this is not polio. But it is not a complete story, and work still continues in trying to understand this unique clinical presentation. So down, or there we go. So in the outline, this is what I would like to cover, and I'll try to go through this. And I understand that after lunch we will have a little bit more discussion around how these patients are treated. But I think I'm going to focus on the higher level picture of what the epidemiology and our investigations are. So in 2014, of course, there was a lot of news around this polio-like illness. And it really was the recognition that there was something unusual going on. And this was more to, we haven't had significant polio events for a generation almost. And so this was disturbing to a lot of people to see paralyzed children in the United States. This is to look at the complementary US data that John showed for globally. That prior to the introduction of vaccines going back to the 1950s and then the early 60s, there were on the order of 15, 25,000 cases of polio in the United States. So a significant disease burden, and of course that generated a significant amount of concern and indeed fear if you had children during the summer and late fall at that time. So with the introduction of vaccine, though, indigenous polio disappeared from the United States by 1980. At that point, the only disease that remained was disease associated with the vaccine. And the question earlier had to do with this vaccine-associated polio, which was largely among the vaccine recipients. This is different than the vaccine-derived polio that John was talking about, that is circulating and causing disease like the wild virus. So that has not been an issue in the United States. But there was disease from still using the vaccine, and it was somewhere between 6 and 10 cases a year. So the United States changed its policy beginning in 1997, and by 2000 the oral vaccine was no longer used in the United States. And the inactivated vaccine was then the vaccine in the routine program. However, as you can see, there are still a few cases of vaccine-associated polio that occurred after that time, but that was related to the fact that people were unimmunized and traveled abroad to where they were exposed to the vaccine secondarily. So this need for a domestic vaccine vigilance still remains for polio, not only because if polio exists anywhere in the world, there is a risk in the United States. And so there is United States programs that deal with vaccination for polio to this day, as well as surveillance for it. The reason this was noted, though, is this was in 2014, was a report of a cluster of polio-like disease that came out of Colorado. And upon investigation, the picture looked remarkably similar, at least at that point. And so there was a request to report these cases as they were occurring. And this was the beginning of the investigation of what we would refer to as AFM, to make sure it was clear that we were not talking about AFP surveillance. Again, trying to make the distinction. This is the data from 2014, and what was remarkable at the time was the coincidence between the occurrence of these cases of AFM and the presence of this one virus, enterovirus D68, that was causing a lot of respiratory disease and putting children in the pediatric intensive care units around the country particularly because of pneumonia and exacerbation of asthma. So there was a large respiratory outbreak occurring, and in the same context, we were seeing these children become paralyzed. So acute flaccid paralysis, of course, is the manifestation that is due to disruption of the function of motor neurons. But there are many different causes and underlying causes of that particular syndrome. But what was particular about this case is because there were a lot of MRIs being done on these children, it was clear that this was a gray matter disease, much like polio. This just gives you a specific example of the focus, and also the fact that there was extensive lesion in the spinal cord, and this was also correlated with the severity of the outcomes. So it does have some of the similarities to polio, and it is, of course, just like polio, associated with sudden onset of weakness. Again, this is a muscle manifestation. You lose the ability to move the muscles. So this was common with polio. But we were trying to make sure, because the first thing we did was we ruled out polio in 2014, because that's the biggest concern was polio reintroduced at that time. So once we were fairly clear that this was not something polio related, then the beginning of the investigation of what is it. And so this is where the overlap between what other things other than polio cause AFM or the disease. There are many known causes, and slowly through continued investigation, many of these were ruled out. So let's pause for a moment to look at, of course, what does AFM look like? And it is indeed a very tragic manifestation for these families. Okay, that's not what I wanted to do. That's what I wanted.
South Fayette first grader used to be very active, but everything changed on October 15th of last year when Bryson was diagnosed with acute flaccid myelitis, or AFM.
We went out to dinner that night, he was fine, and then the middle of the night, Saturday into Sunday, he was up vomiting. Just once that night.
AFM hit Bryson hard. He went back and forth between the PICU at Children's Hospital and inpatient rehab for months.
So as we heard earlier this morning, this presentation is remarkably similar, and this is, of course, a major concern. Is there something that some other virus is occupying the niche that polio had, and that is going to be the polio of the future? So this is, increased the need to further investigate this, because it's not only what is going on, but what is the future related to this. So if I can see if I can move this again. Let's see. Okay. So the clinical presentation, as I've already mentioned, is a spectrum that does indeed have a lot of overlap with some of the manifestations of a polio infection. So I won't go into all of these, but the problem being is differentiating this from other neurologic disease. And so this was part of the reason for trying to get the specificity around AFM so that we could focus specifically on this manifestation and not deal with a background of other neurologic diseases, in particular things like transverse myelitis. So that's where we did have the need to have the specificity to contribute to this investigation. So back to the epidemiology. This is since the beginning, on the far left back in 2014, there has been a 2-year pattern. So 2014, 16, and 18 were the peaks. They are occurring at the same time of year, every year. The peaks are September, October, and of course, if there was something happening this year, it would be starting around now. But we don't know, so we're prepared whether it starts now or next year or the year after, because predicting patterns like this is always a little dangerous. But this is what's going on in the United States, and last year was the greatest number of cases, with 235 cases confirmed last year. It is widespread across the country. There are 41 states that were affected last year, so it is not something that is geographically focused. This is different than polio. Polio, when it was endemic in the United States, had a very much geographically skewed presentation, where outbreaks were far less common in the north, and so you would have periods of years when there was no polio just because of the seasonality. And in the south, polio was nearly year-round. So there's a bit of difference in the epidemiology as well, but as you can see, it is not restricted to one part of the country. These are the characteristics overall of the patients. These are now on average 5-year-olds, but you can see 75% are between 3 and 8. And there are still a few, but most of this disease is in children. This is certainly older than one might expect if you were to have something that was a brand new disease where nobody was immune. So there is a bit of a difference there. There is a male predominance, which you also see with polio. And there is nothing really unusual about the race distribution. The clinical characteristics, almost all of these children are hospitalized. There is inflammation that you can detect in the cerebrospinal fluid. And as you can see, the number of limbs that are affected are variable, but also there are a significant number of children that are quadriplegic. What is different is that there is much more predominance of upper limb involvement than what is typically seen with polio and lower limb involvement. And this is consistent with the MRI findings that are more cervical than thoracic. So there is also another key feature in that almost all, not all, but a lot of the children have a preceding illness that looks very virus-like, whether it's respiratory symptoms and fever or sometimes gastroenteritis. So a very non-specific, typical, if you've got children at that age, they're always having sniffles and things. So there was nothing in distinguishing their preceding illness from other common colds. So this makes it a consistent finding, but it's also hard to then separate from the millions of other children who have these symptoms during this period of the year. There's a significant part of the investigation that has to do with laboratory testing. What has been very frustrating is that it has been almost no viruses detected in the spinal fluid from these children. And this is making it very difficult to assign an etiology, a cause. We would expect to be able to more consistently find a virus. The one virus mentioned there, enterovirus A71, has been known for 30 years to be associated with paralysis, but it's often presenting more often as an encephalitis type picture than a strictly predominant AFP like polio. We had, unlike polio, we also had a remarkably low rate of detection of any virus in stool samples. Again, since we were testing for polio to rule out polio, these samples were tested just like surveillance around the world. The respiratory samples, however, half of the samples were positive, and so overall 1/4 had this enterovirus D68 that I mentioned was associated in 2014, but 20% had some other enterovirus. It's in the same family of viruses as poliovirus, but these are distinctly different viruses and included other rhinoviruses, which is one of the common causes of the common cold. So this has been part of the challenge because we're just not getting definitive answers from the testing of the clinical samples. So at CDC, with partners, we have multiple activities underway. Again, trying to understand better some of this epidemiology of the disease itself. We do see this seasonality. We do see this 2-year periodicity. But we're also trying to get a better idea just in terms of characterizing some of the other epidemiologic features. There are simple things that we're doing for the 2018 cases, like going back and interviewing the families. Do you have a dog? You know, and these kinds of things that are more ecological to try to get some hints, because it's still a rare disease. But at the same time, one of the least satisfying answers, just like for polio, is why did my child get paralyzed and not somebody else? And even with polio now, we don't know the answer to that question. So you hate to tell people the answer that it's just bad luck. So we really do want to try to understand whatever this virus is, or viruses, plural. We want to understand why certain children are becoming paralyzed. So we are setting up formal studies as well to be able to link this epidemiologic investigation when we get cases reported to a more comprehensive set of laboratory testing, as well as independent research on different ways of animal models or other types of testing of new assays. And of course, the other area, of course, is the communications. You've already heard the vital role that communications plays in polio, but I think that it's also important to realize that new conditions present a considerable communications challenge. One of the reasons of which I'm here is to help with explaining some of these distinctions and why this isn't really polio, but it is very similar. So these are summarizing some of the similarities and differences. So it really does look a lot like polio, with a couple of the exceptions that I've mentioned. We don't understand the preceding virus-like illness and what is its role in the disease development. So there is the etiology approach, but there's also the approach of pathogenesis, which is trying to understand the mechanism that an agent would induce this disease. In polio, it is the direct replication of the virus in the motor neurons in the spinal cord. So it does not seem to be that simple in this situation. So we are working very hard to try to establish evidence around the etiology. The bad news is at this point we have no prevention strategy, unlike polio where we clearly have vaccines that are effective. So at this point that does present a challenge to dealing with AFM, and there is work that is progressing on both development of potential vaccines, but also antivirals that may pose a challenge in terms of being effective by the time a child presents with paralysis. So we are on a 2-year cycle with 3 rounds that have occurred, but I've been studying enteroviruses and polio for a long time, and the one thing I learned is don't predict. So it may happen in 2020, but if it happens this year or in 2021, that would not be surprising. We are having a leading hypothesis that enteroviruses, singular or plural, that's part of our leading hypothesis at this point, since they certainly can be responsible for that preceding illness. But the role that that illness plays in the paralysis or the mechanisms of how you go from that illness to paralysis is not clear. We are certainly doing enhanced surveillance, probably the best surveillance we've had in the United States for 30+ years for polio. So we would be in a position to better detect importations of polio in the United States than we've had in a long time. And just a few weeks ago, we also had vital signs where we were encouraging clinicians to be more aware of reporting these cases so that they come to our attention on the public health side, as well as trying to be able to get their connection to specialists, the neurologists, communities that are quite willing to contribute to treating these children. One of the things that, of course, John and everybody in the program often fail to do is to, of course, admit that we have a huge team behind all of our work. We get to stand up here and talk about it, but it really is a very large team that has worked on AFM. The problem is all the polio people wouldn't fit on a slide, so I'm sure that's why John didn't include one. But in particular, I would like to acknowledge that Janelle Ruth is here today, and she can answer real questions you might have if I can't.
Janelle, if you would, stand up, please.
Yeah, stand up, Janelle. Okay. And so we do keep information updated on the CDC website. Encourage you, if you have, would like to look at additional information. But there, of course, are ways to get to CDC through our usual mechanisms and email accounts. So with that, thank you very much.